Hello, everybody, and welcome to the Doctors of Running podcast, where we, a group of doctors of physical therapy, discuss the art and science of running and the stuff that we put on our feet. My name is Nathan Brown, and I will be hosting today. And today we have a very exciting guest. This is somebody who has been on the podcast with us before. It is Doug Adams. He's a physical therapist, founder of Run DNA, and he also was the physical therapist for Tin Man Elite, has a ton of experience in biomechanical analysis of runners, has been working in the biomechanics of walking as well. I have been having the privilege to have done a lot of his online courses that he's created. There's a lot of things for people who want to learn more about endurance running from a coaching perspective, endurance running from a biomechanical perspective. He's a wealth of knowledge and has found ways to share it with the world. So take advantage of learning from him today. We're so glad that he joined us. Doug, thanks for taking time to join us today.
Nathan, thanks for having me here. Excited to be back. It was a fun conversation last time and looking forward to this one.
Awesome. And we're lucky because we have been asked a lot of time by the people who've been following us on the podcast to have a discussion about plantar fasciitis, plantar fascia pain. And we know that there's a lot of complexity in this topic, and we could have just had the discussion among ourselves, but we thought that bringing someone else in with another perspective, especially thinking about biomechanical implications for this condition, we're excited to dive into everything plantar fascia pain with you today. So before we jump in, though, I would love for you to give people a little bit more introduction about who you are and kind of what you do and what has been kind of sparking your passions over the last 6 to 12 months.
Oh, yeah. All right. No, I have lots of soapboxes, too, so that's always fun. But
hey, we'll take it.
I'm a self-proclaimed Gait geek. I love everything about running, walking. It's just something that has been so passionate for me, and I've been very fortunate just to have the opportunity to work through that in my career. Started off in a little bit on the academic side and then spent some time on the more commercial side working as a physical therapist. Got kind of frustrated pretty quickly, not having resources and tools. So started teaching courses, started building technology, and that's kind of what has brought us here. We've been very fortunate, in the professional runner space, a lot of adoption there. In the military space, a lot of adoption there. So I just spend my days, I get to make up lectures and create new cool technology and work with high-level professional runners as well as local recreational runners. Now, a lot of the stuff that we're talking about today, it's not just for the pros. And I think a lot of people, they look to emulate the pros at times, but I'm always like, hold on, you might not want to. They're not perfect. Sometimes they're professional runners because they're really good at getting through injuries, and they don't necessarily have perfect biomechanics. They just have huge engines and are able to get through some of that stuff. So, as far as what I've been working on the last 6 to 12 months, I think one of the biggest things, and I think very relevant to what we're talking about today, is how much we should be really looking at our walking patterns, even as a runner. And that's something that I think has been huge. And personally, I had an experience when we were developing some new technology that my walking made a huge difference in my running. So that's something I'm excited to share as well.
Fantastic. Well, when you talk about some of the technology, I'm a personal beneficiary of the technology that you've worked on. A lot of people know this already, but I lead a biomechanics running lab at our university with our DPT students, and we utilize Run DNA's Helix 3D system as a way to bring all of the runners at our university through a standardized examination. We're both doing kind of preventative work, but also if they've got something going on, we bring them in, we take a look at mechanics, strength, mobility, all that stuff. So thanks for creating a technology that is mobile and small enough to fit into our spaces, because we don't work at an R1 research institution where we can have this, 20 camera system, and we don't have that sort of funding and resources. So thank you for the work that you've done over the last how many years ago did you establish the Helix 3D system?
I think the first version of it, I started working on it in 2016.
Okay.
And I want to say 2017 was the first version that weighed about 25 pounds, and we called it portable. It was milled out of a piece of aluminum.
That's amazing.
So yeah, portable was a relative term, but yeah, so we're getting close to 10 years of it here.
Cool.
But that was, talking about soapboxes, and, kudos to you for doing that. And we're getting a lot more universities that are starting to use it as a teaching tool. We're talking with a couple this week. But it's been really fun because we taught this course this past weekend. We did a little team after action review, and we're kind of surprised. And I see this, that people aren't as knowledgeable about gait as you think that they would be. Mm. And a lot of times I think that was because we just didn't have a way to objectify it or measure it before. That you couldn't get good data about it. So why spend a ton of time learning all about the biomechanics and how to make interventional changes there if you can't measure it in the first place? But now what we're seeing is that as there's more and more tools and more access to that, people are actually starting to really care about their gait. Both the runners, like I love that runners are asking for gait analysis now. Right. It's not like, hey, let me tell you about this cool thing I can do. A runner's, hey, do you do gait analysis? Which is really pretty cool to see.
Absolutely. Well, here we go. Let's start diving into the topic of the day. We're going to be talking about plantar fascia pain. This is something that I think is so important to talk about for a few reasons. One is how common it is in the running population, but also in the non-running population. And I think that's where some of this conversation maybe about walking gait can come back as well, because I think it's, depending on your statistic and what study you look at, somewhere of like 1 in 10 people will have plantar fascia pain at some time in their lives. It's one of the more common on the laundry list of running related injuries. And in my opinion, it's one of those that's a bit more of a bugger, because there are a lot of things that it could be, and it's sometimes a little bit more stubborn than some other tendon related issues that are somewhat easier to manage. So what we want to talk about first is just what is the plantar fascia and about the anatomy at the bottom of the foot. Do you mind kind of enlightening us on some of that?
Yeah, especially you could dive deep into this because there's layers of muscles, and there's a third of the bones in our body are in our feet. So there's a lot of intricacy with the foot, and I think that's where it can be intimidating at times. But if you just look at it at a basic level, the plantar fascia is something that is used as a way to maintain the stability of our arch, which is important for how we accept load and create forces. So we basically have this really thick fibrous structure that's at the bottom of the foot that is just a great way to maintain it. And, the Romans had it right. Maintaining arches is a big part of it. It gives us a lot of stability, as well as ability to adapt to the ground. So that plantar fascia has a very important role in what we do, which is probably why we're seeing so many people have it. And 100% agree with it, Nathan, that we see people often, these symptoms persist for a year or more, where people can even be up to 10 years after they develop it. It's actually interesting. I'm having a little bit of this pain myself right now, so this was even really relevant timing for me. And reviewing some of the literature and doing my own gait analysis, I was like, oh, yeah, okay. I need to do as I say a little bit here.
That's fantastic. And when we think about, I would love for you to even go into some of this complexity of the layers of the foot. So we've got this plantar fascia, which is kind of that almost most superficial layer close to the skin. Talk a little bit more about what's going on underneath there.
Yeah, so then there's a series of muscles that we refer to as both intrinsic and extrinsic muscles that contribute to how the foot functions. So we start to have some of the muscles of the foot that start to control how we start to flex. We start to see around the plantar fascia, we're going to start to see some of the toe flexors. Then as you get even deeper, you even get into smaller muscles like the interossei, which start to control the relationships of the bone as they get to each other. So there's about 3 or 4 layers that we really go through. And there's all sorts of names, and there's a lot more needling now, which if you get dry needling on your feet, man, that feels all sorts of special. But there's a bunch of intricacy with that, and a lot of it is to help. I often describe the foot as not really something that's very strong. It's something that's very coordinated, and it's very smart. Although I will say, Courtney Connolly has got me on to this. I am doing a lot more of assessing toe flexor strength and looking at that. She and I have kind of collaborated a little bit more over the past year or so as well. And she had some interesting statistics about how much the toe flexors are part of balance and risk for fall. And an older population starts to lose a lot of strength in some of those muscles. So if we look at any population, if we are starting to lose the strength of those layers of muscles that we're talking about, what we're going to see is that we're going to rely more on our passive structures, like our plantar fascia. So that's really where this fascia is more of a passive structure. And we have dynamic structures with our foot intrinsic and the extrinsic muscles, like the tibialis posterior that supports the arch. Those muscles, if we start to lose strength in those, then there's going to be more mechanical stress at the plantar fascia. And what they found is that they used to call it plantar fasciitis, right?
Yeah.
And now they call it more plantar fasciopathy, because they're seeing that there's not actually a lot of inflammation locally at it, that it's more of a mechanical loading and mechanical tissue issue from repetitive stress that is causing changes in the structure of the plantar fascia. And it doesn't have a lot of the elastic properties that it normally has when it's a healthy tissue. So if you don't have the strength of some of those intrinsic and extrinsic muscles, you're going to be putting more strain on your plantar fascia. And now I don't know if we want to dive into why people start losing strength here. That might be a little hot topic, but
maybe. I think there's some interesting things, especially as we talk about footwear too. There, it would be interesting to go into some of that. I think you've just hit a couple really important things. And one of them was the passive nature of the plantar fascia. The other one had to relate with the fact that it doesn't have these inflammatory markers. Can you tease out for people who may not be like, okay, why does it matter if it's itis versus opathy? Can you flesh that out in terms of how treatment then may look different and kind of how we conceptualize what's actually going to help?
Right. So theoretically, in the early stages, and everyone's a little different, and we should also, maybe for a second, also say that not all plantar foot pain is plantar fasciopathy. So somebody having pain on the bottom of their foot, that doesn't mean that you have plantar fascia issues. There is a whole different level of differential diagnosis that we can really start to see based off of. I think it's probably easiest for the runner to think about the differential diagnosis by the location of it and the behavior of it. So exactly where you're getting the pain is a big part of it, because just having pain on the bottom of your foot doesn't mean that it's necessarily coming from the plantar fascia. Then the behavior is also an important thing, where we see that the typical behavior of plantar fascia issues are going to be that first step in the morning is very painful. You're going to see maybe, especially early on, it does start to get a little bit better with activity as you loosen things up. Whereas something like a nerve entrapment is not going to respond the same way. And we know that there's a couple of nerves in the area. Baxter's nerve is probably the one that is most common that we see there, where it gets inflamed. There is a local inflammation around there, and that's causing pressure on the nerve, which is contributing to pain on the bottom of the foot, but it might feel very different, even though it's in a similar location with it. So that's kind of a quick aside about that. Then going back to the inflammation versus non-inflammation and why that really affects the treatment is that our body heals in the presence of inflammation.
Yeah.
We need inflammation. That is a critical step in the healing process. And most people don't realize that. They just think all inflammation is bad.
Right.
And that's not the case. Inflammation, there's a couple different stages of healing. And what happens is that first inflammatory process is bringing everything in that is laying the foundation to rebuild the tissue. And that's really important. And oftentimes we stall out and we don't get that healing response. So it becomes more of a fibrotic type tissue a lot of times. And then if you have inflammation, it's like, okay, let's manage the inflammation, let it do its thing. Obviously too much of a good thing can not be good. But in the case of a plantar fascia issue that is maybe more chronic or has been around for a long time, we need to bring some inflammation to the area. That's why we're seeing there's a lot more evidence now, and some of the emerging evidence is really around that extracorporeal shockwave therapy. And we're seeing that is a big treatment that's gaining more literature, as well as low-level light laser therapy. Those modalities have been seen to have an impact. And personally, I also see a lot of benefit. We use like windback Tekar therapy, and I've seen that do a really good job just because of its ability to get certain depth of tissue. So when we're thinking about how we get treatment, things like PRP injections, shockwave, we're looking at those types of things like that needs to be something that we consider as we're trying to bring inflammation in and remodel the tissue a bit there so that we can get that healing response that we're looking for, because it doesn't have the blood supply that we're looking for. And that's why people have these prolonged symptoms with it.
Yeah. And it's a huge paradigm shift, when you go from something and it's like, oh, this has been thought to be the malpresence of inflammation for long periods of time, when in reality, there's no real inflammatory markers present. So you're not trying to treat inflammation. That isn't the goal. Where I think for a long time, that was the perspective, where it was, hey, let's do the things to, quote, get rid of inflammation. Let's ice it. Let's whatever it is, and take anti-inflammatories. And those things just won't solve the problem with plantar fascia pain. There's a lot more going on. So you talked about some of the symptoms too, and kind of differentiating the location. And if you had to describe, because the arch of the foot's a pretty big surface, there's a lot of length there. It's all the way up to the toes. It's all the way back to the heel. Where's the most common area along there where people will be like, oh, this is probably a plantar fascia related issue versus something different?
So if you're looking at your heel bone, which is the calcaneus, there is a bit of a spot that if you find it and you're having plantar fascia, you'll know right away. That calcaneal tuberosity, like if you get on that medial calcaneal tuberosity, like I'm poking mine right now and I can feel it and it's tender. But basically, if you take your fingers and kind of come and run your fingers alongside the inside of your arch, right at the start of the arch as it's closer to your heel, then run your finger down towards the bottom of your foot, you'll run over this bony spot. And that is an area where the plantar fascia, the medial aspect of the plantar fascia, because there is lateral plantar fascia and some different things too, but most commonly we see the medial. That's where you'll see origin symptoms. There is a subset of the population that gets it more mid-portion as well. And that's where they'll feel the symptoms. I find often they'll still have some of that tenderness at the origin. Yeah. They'll just notice it more at the mid portion of it. But I find that group has a lot of soft tissue with some of the intrinsic muscles of the foot, the toe flexors, quadratus. Like I find that a lot of those are actually muscular issues as well when it's more mid-substance or mid-portion plantar fascia.
Perfect. So let's kind of transition to start talking about how you as a physical therapist think about kind of diagnosing and treating this, not diagnosing the condition, but diagnosing the root of the problem and what needs to be addressed. So this could be wherever you want it to go. If you want to talk about clinical exam or mechanics of gait or kind of combine them, I just want to hear kind of where does Doug Adams' mind go when thinking about how to approach management with patients that you work with?
Yeah, it's a great question. We could go a lot of different places with this. I think it needs to start off with curiosity and really understanding what led to the mechanical overload. Was this a issue where there was excessive tightness in the posterior chain and that was changing some of the mechanics and that tissue got overloaded? Are there gait changes? Is there inadequate footwear? There's so many different things that could be contributing to it. Is the first metatarsophalangeal joint, like the first ray? Are we seeing stiffness? Is there limited hallux extension, the big toe, right? There are so many different things, and everything kind of meets in the middle, right at the plantar fascia. So if you have a limited big toe motion, for people listening out there, right? What we see is there's this mechanism called the windlass mechanism. When your big toe bends up, we need to see the arch raise up so that there's limited excursion of the plantar fascia and it's not mechanically changing as much. So if we see changes in how somebody is pushing off, or if we're seeing that somebody has limited toe motion, it's part of our runner readiness assessment is having somebody do an active hallux extension, big toe raise there. And if they're not able to do that, we might need to look at that as a potential contributing factor. But you have to be very curious and try to work backwards and figure out what is the root cause of it. Like, where did it come from? Mm-hmm. Do they have limited ankle mobility, right? I'm a kind of a big joint mobility person myself here. I find a lot of foot limitations, especially in the running population. What we're seeing is that we have to act as such a rigid lever with our foot that sometimes if you don't have strength, or if you're not setting your foot up to have enough feedback, we'll kind of say that way. If you're not getting enough feedback and setting your foot up in the right position, you're going to start to see that there's going to be changes. And a lot of joint mobility issues start as stability issues, where somebody can't control their foot as well, and then they stiffen the foot and it becomes in this naturally stiff position. They don't go through as much excursion because they can't control it. So we have to take a multifaceted approach to this, where we need to restore normal joint arthrokinematics. So how your foot joints move, restore that first. And then we need to start training the stability. And we really have to look at those two together. Then that doesn't stop there. Now we have to go to the biomechanics, because if you've changed your biomechanics and how you're walking and how you're running, you're still going to be putting stress on those tissues in a way that they're not normally designed to. That's a lot. I know I just threw out I don't know if you want to dive into one of those things. I was going to maybe go into like the Gait stuff, or you want to talk about some of those different topics there.
I think we could totally transition into Gait, because I think what I heard you say, your first line of defense not line of defense, but your first curiosity button sounded like it was mostly on this idea of mobility across the chain from toe up through the back of the hip, and looking at how's your hamstring mobility? How's your calf mobility for like these soft tissues? How's your ankle joint mobility? How's your foot mobility? Let's get mobility squared away. Because if you don't have the mobility, you can't do anything else with it. So you got to get the mobility where it needs to be for the tasks of running. So that was kind of like a step one. And then it's like, okay, how does this mobility play out when you actually start to move? So yeah, let's go into this biomechanics. You can talk about running or walking, whichever feels most appropriate. Talk about what are these common things that you see for people who have plantar fascia pain that pop up on their running analysis, that it's like, this could be a contributing factor.
Yeah. And just one last kind of note on the mobility. This might be a little bit of a hot take, but I'm going to challenge the physical therapist. There have been few feet that I've met that can't get more mobile. You got to work hard. It takes a lot of strength and it takes a lot of like joint mobilization technique and skill, but there's rarely a foot or an ankle that you can't get a little bit more motion for here. So oftentimes when I get people that come to my practice that haven't gotten results otherwhere at other places, and they say they did some of it, and I say, well, here, tell me if this feels the same. They're like, no, this feels entirely different. So develop your manual skills, or if you're looking for treatment, make sure that people are like at least assessing that and seeing if it's there and intervening with that. And that people will challenge me on that. Like, by all means, put comments like let's have a conversation here, because I think that that's important. So,
And actually, before we move on, you're kind of sparking a thought for me. I think something else that you're pointing out that I think is important is I think a lot of times we can talk about this concept more because I know there's a lot about what I'm about to say. But I think a lot of times the motion and movement that is demonized is what people coin as excessive pronation or too much over pronation. And what you've been talking about is a lack of mobility for the so far. And I think that's been borne out in the literature as well as a risk factor for plantar fascia pain is this lack of mobility and not having enough pronation because it's such a stiff foot, and then it's relying on all these passive structures, which comes into this plantar fascia overload issue. So I just wanted to throw that out there kind of as a little bit of a mythbusters, because I think sometimes it's like pronation's the demon that we got to get rid of. But we're talking about the fact that too stiff of a foot is actually what you're seeing, what the literature bears out as well. Like that's definitely part of the problem is not enough mobility.
So we got to start that. And that's a great segue into the biomechanics of it too. Because now we're starting to think about, let's start first before we talk about the biomechanics and how people change it. Let's talk about the role of it. We talked about what the plantar fascia is, but let's talk about the role and what it does. Okay. So with walking gait, we see that it's primarily a stabilizer. But we're seeing it really is, there's some rockers. If you learn that in school, the first rocker, the second rocker, the third rocker, it's like what we see is that middle rocker, we're trying to stabilize the arch and we have to lock down that midfoot. Like we need to be able to progress and vault ourselves over as we're walking and progress the body forward. So in walking, we're seeing it's about 1 to 1.5 times body weight that the strain of the plantar fascia. Now, when we go to running, what we're seeing is it stabilizes the arch, but it is actually part of propulsion and an elastic structure now. So now it's actually going to contribute to a little bit of the efficiency of our movement. And I say this, and it's kind of an oversimplification, but running is largely passive. And what I mean by that is that if you load your tissues up correctly, we get a lot of passive benefit, which is what makes us efficient runners as an animal, as a species. We're efficient with our running because we've got a lot of these structures that can store and return elasticity as we go. And the plantar fascia plays a role with that. And it undergoes about 2 to 3 times our body weight because of that increased role. It also does that in a very short amount of time compared to walking, where the ground reaction or the ground contact time for walking is 2 to 3 times as long. So not only is it doing more weight, but it's actually doing it in a shorter amount of time, which is going to put a significant amount of strain on the plantar fascia. So what does the literature say, and what do we notice, and what do we see a lot when we're doing analysis with this? It's interesting, chicken versus egg, and I haven't found a lot of great prospective studies there about who develops it versus who doesn't there. But what we know is when somebody is having plantar fascia issues, our body is actually pretty good at compensating for it. But what they're finding in the literature is that a lot of those compensations and those pain modulating activities that we do might be contributing to why these last for so long, why people are having a year to 10 years of symptoms with this. That's what we're really noticing, is that some of these modifications might actually be contributing to that. So you mentioned pronation. What we see is when they look at it, and some of these studies are really hard to do because getting very finite foot mechanics, it almost requires you to put a marker directly into the bone and to be able to see some of that on a very large system. And that's challenging to do. So on a more clinical side, we're looking at the rear foot. We're seeing what we can do in rear foot inversion and eversion, which is also called supination and pronation. And that's what we're seeing. But what we see in this plantar fascia population is not necessarily that they're always overpronating, but their excursion from supination to pronation is a higher range, that they're starting a little bit more inverted. So they're landing a little bit more on the outside of their heel. And then they're still going into pronation, but they're starting from a little bit out here to try to avoid pressure directly on that medial aspect of it. Mm-hmm. So to modulate pain, they stay a little bit more on the outside, even though that's a little bit more rigid structure, which maybe is the part of the long-term effects of that, that we're putting more stress on it because we're going longer through, but our body naturally doesn't want to put pain directly on that. So it's not even always overpronation that's the issue. It's that we're landing a little bit more supinated, and then we're going into normal, maybe slightly excessive pronation, but the range of that is a lot, and that causes a lot of stress on it. Then we start having to engage our tibialis posterior more, and we're looking at our abductor hallucis. We're looking at all these muscles that are going to have to do a lot more work and putting more mechanical stress on the area. So that's one interesting one. There's another one too, but I know that was some of your thoughts with that too. I don't know if you have thoughts on that as well.
No, I think that just makes a lot of sense. And I think it puts the idea of pronation for people who have just automatically put that in a bad category. It brings some nuance to it. It's not just how much movement you have in your ankle and how far your foot is flattening out or how much your arch flattens. It's not that. It's how are you moving? How much total motion is going through there is kind of what you're saying. And is that amount in a very short amount of time increasing the total load through that structure? So and then the solution is not avoid pronation. The solution is different than that, and it probably has to do with things that are not just changing how you run, but the underlying purposes underneath. So feel free to go into the next one, but I love what you said there.
It's a great point with that too. We just we have to consider some of the nuances with it and the velocity. So one of the things, I don't think a lot of Helix users look at this. So if they're listening, challenge yourself a little bit, but looking at angular velocities and angular accelerations. And if you look at the amount of angular velocity and acceleration on somebody that's having plantar fasciopathy, you're going to see a lot of times they're elevated. So it's a lot of tissue structure in a short amount of time. And the reason that is we strive for symmetry when we walk. So if you're going through longer excursions, but you're keeping the same amount of ground contact time and the same, I think what I found with doing a lot more walking gait analysis now is that people tend to try to keep the same step length. Step length seems to be the default that we're noticing here. And I don't have a lot of literature, or I haven't seen studies that specifically have looked at that. But it seems to be that if walking, at least, step length is everyone's trying to preserve that. But they're going to change how they do it. Sometimes they're taking a longer swing phase. Sometimes they're doing quicker on the ground. Plantar fasciopathy patient might try to really limit the amount of time that they're on the ground, and then they're coming down hard on the other side, which is why eventually they get bilateral symptoms with it here. So that's just a little side note. But the other thing that we see people do is they tend to land, and this is definitely, the studies are a little bit more limited to this because it's hard to see and not everyone can do the studies, but they tend to land in a little bit more of a higher arch position to see if they've got a little bit of a buffer to get in that position. But then what happens is they're going through more mechanical load because they're trying to modulate pain at initial contact. So they found that the first metatarsal phalangeal joint, the knuckle joint at your big toe, is often a little bit more plantar flexed as a way to try to elevate the arch a bit more. So then that's going to just they're trying to steal a little stability, but then it goes through more deformation, and now you're seeing more strain on it. So both of those things are actually, if you're really effective at treating plantar fascia pain, whether you're a runner or a walker, I have to stress that runners need a walking gait analysis too, because you might get your pain at certain points, but I think a lot of people would agree with me, and this is what I'm experiencing right now with plantar fascia pain. I'm fine running. It's those steps when I'm done running that like I start walking and do my cool down and I'm like, oh, now my foot hurts, but it doesn't hurt when I'm running as much here. But you should really get a walking analysis too, because what's happening is we're taking a lot more steps when we're walking, and each one of those steps could be helping or harming us. Yeah. And if you have some of these deviations in your gait, you are putting cumulative stress on your tissues that then when you go run, you're going to exceed that structure's capacity because it is more stress, faster, larger excursions, everything that we already talked about. But it's every step that you took leading up to that that really contributed to why running is something that they say, oh, well, I'm fine if I go run. Then the next day I really start to have a lot of pain when I get out of bed.
Yeah. Well, outside of those two, are you seeing anything else with amount of dorsiflexion or knee mechanics, hip mechanics? Is there anything else that you're seeing lining up for folks, or are those kind of the primary ones that you've been locking in on?
Those are the big ones that I lock in on, but there are some other ones. Ankle dorsiflexion is often limited. We're going to see that ankle dorsiflexion, and then there's going to be a bit of an early heel rise. A lot of the other biomechanical literature talks about there's a lot less ground reaction forces, like kinetically. We've been talking about kinematics, but kinetically, there's a lot less push off there. So that's going to change some of the other structures and how they contribute to gait. We mentioned with the mobility, and I like that you keyed in on, we have to check out the whole posterior chain. Like we have to look at the hip, we have to look at the pelvis. I have found like this is kind of a cool biomechanic thing that is not often looked at, but something that I look at a ton with our Helix 3D system is pelvic rotation. Okay, we've talked about pelvic rotation before, but I don't think a lot of people realize, our foot and ankle and our shin are linked, and it's like a mitered hinge joint, it's called. So the two are linked with a lot of this. So when we land on the outside of our foot, and then we roll towards the inside, pronation. Then we have to roll back to the outside. That is another way to think about that is thinking about external rotation. We are externally rotating. So we're coming out of hip adduction, hip internal rotation, pronation as we're in mid stance. As we get towards the end of our stance phase, walking and running, we have to kind of externally rotate. So somebody that doesn't have enough ankle dorsiflexion was going through this, what are they going to do? They're going to really turn out the foot. Now they're loading up the tissue in a torsional manner. Yep. And they're actually like putting a lot more stress on that medial side of the foot because they don't have the ankle dorsiflexion. Now, one of the other things, getting back to pelvic rotation, this is kind of a cool thing that not a lot of people key in on here, is that your swing limb actually helps to externally rotate your stance limb. And if you're having trouble like visualizing that, stand up and try it, right? So stand and let your leg kind of collapse in, and then bring your other leg forward. And what you'll see, because the adductors on the leg that is in swing are connected to your pelvis, as you're rotating your pelvis forward, that's bringing the pelvis forward, and it's rotating the opposite side back, which is externally rotating from the proximal aspect of it. So starting from the hip down, we're starting to see that as that swing limb comes forward, the other side starts to go back, rotate out, gets us out of that pronation, back into supination. And now we're seeing that is going to put us in that rigid lever that we need to push off. Okay, so if you are not having good pelvic rotation on your swing limb side, you're asking for a lot more work to externally rotate a lot more manually and having to do a lot more activity with it, whereas it should be a passive type thing, which is why we don't see a lot of glute max, which is an external rotator, we don't see a lot of activity of that latent stance, but you will see sometimes activity of that overactive glute, sometimes if we're not getting some of that pelvic rotation. So that's a little different one. That's pretty in the weeds, and I'm sorry for everyone that's not like a biomechanics person. Sorry for I might have lost a few people there. So come back. We'll get more relevant, but that is a cool biomechanical thing.
I think to bring it home, like we just talked about some pretty in-depth biomechanics that some of us followed and some of us didn't, but that's okay. What the heck do you do about it? So if you're working with a PT who's seeing these things, like what do you do? Like, is this a change your gait? Is this a work on mobility? Like what's the solution?
This is like gait retraining, and I am totally biased with this because I've made a career around gait retraining, but I've helped first timers to first place in the world, right? Like these are gold medalists to first timers. Gait retraining is a huge aspect of this. And here's the important point. I'm glad you say let's bring it back, because this is not hard to fix if you've identified the root cause.
Yeah.
We talked about that pelvis. You just need to do like a little bit more arm swing. That's going to get your pelvis moving a little bit better. That like simple. Okay. So we're seeing that the foot is landing a little bit like plantar fascia, right? We're going to say, hey, focus on knee, drive the knee a little bit more and relax your foot. It doesn't have to be extremely difficult changes with this. Yeah. The secret sauce is in figuring out what's the primary thing that I can really focus on. And that's where a truly objective gait analysis is going to help you to figure out what's the chicken, what's the egg, where do I need to focus on? And getting a gait analysis is going to be a big part of that. But the fix is relatively easy once you've identified it. Like the mobility. Okay, hey, like you're going to start doing some calf raises with your toes elevated. That's an exercise that's been studied very well. A heel raise in toe dorsiflexion, right? You basically roll up a towel, make your toes kind of come off the ground, and you do a heel raise where you're coming up and working at your calf. That's a pretty well documented exercise that works well for plantar fascia patients. So these fixes aren't hard. It's knowing when to do them, who for, what type of plantar foot pain. It all comes back to that personalization where there's no one thing that can fix everyone.
Well, I think I'm glad you said some examples of what it looks like to gait retrain, because what it does not look like is saying, hey, you're landing a little, 7 degrees out on the outside of your foot, make that like 4. That's not the cue. The cues are so much more intuitive and understandable, and it takes trying the cue and seeing, did the cue accomplish the goal, which means you have to reassess the gait again. And so it's, if you're someone who has access to a PT who's doing this kind of stuff, it's not going to be you learning how to understand the difference between 7 and 4 degrees. You're going to get cues that actually make sense to you, which is great. But I want to kind of push.
Great point there. Sorry, what's like the reassessment? I want to like hone in on that because you're 100% right. A gait analysis isn't a one-time. Here's what I'm doing. I suck at walking or I suck at running. The gait analysis is like, here's our first plan of attack. Let's see how we can fix this. Let's see how we can do it. So it's not a one and done. So sorry to interrupt, but I love that you brought that point up.
Yeah. So here's kind of the next part I want to bring back. You talked about this toe flexor strength. I think mechanics are one part that we can change, which sometimes takes some guidance from someone who really understands what you're looking at. Something like strength, people typically engage in regularly. They're often strength training. They're doing all these things. What have you seen about kind of decreased toe strength, maybe some perspectives on footwear and how that plays into things? I think that plantar fasciopathy, plantar fasciitis, plantar foot pain, and the orthotics world are one of my biggest soapboxes that I could also go up on. And I will hold my tongue until it's appropriate timing, and then I'll jump in too. But what has been what's your perspective on kind of what you've learned about this foot strength and how we can think about that if we're dealing with plantar fasciopathy?
Yes. Great. But it's also funny. You and I, I'm older than you, but like when we were in school, even it was like plantar fasciitis.
Yeah.
So both of us have a little hesitation. Plantar fasciopathy. You have to, fasciopathy, like not itis. I find both of us like stopping ourselves there. It's like, I want to say the right thing.
Yes.
But anyway, so to answer your question, a little bit of a oversimplification, but a key takeaway about the role of strengthening your foot in treating plantar fascia pain is it should just be part of your everyday routine, and it doesn't always necessarily have to be a set group of exercises that you're doing in order to strengthen the foot. Now, yes, you go to, you have an injury, you go to physical therapy, you might be doing specific exercises. The role of those exercises is to increase the connection between your brain and your foot and enable you to correctly recruit and use the muscles that we're talking about here. However, true tissue capacity, that was what we're kind of talking about here. So the ability of the tissue to absorb forces and generate forces. What we really see is that it has to be part of your daily routine. So this is where footwear does come in. And this can be something that you can do with your everyday routine. I know most gyms won't let you do this, but doing your strength training routine in barefoot or at least minimalistic shoes can be a huge benefit for developing foot strength. You're doing lunges at the gym, you start doing them in a pair of zero shoes, and all of a sudden you're going to get a lot more benefit for what you're seeing, the recruitment of those muscles that we've been talking about here. Now, like we said, some of the banded exercises that you're doing, you might need to learn how to reduce tonicity, right? A muscle that is not healthy might not have the right firing patterns where it doesn't fully relax in between each contraction. And you need to teach it how to do that. But the long-term plan is you need to incorporate this into everything that you're doing. This is something that I do. I wear a minimalistic low drop or shoe all the time. I am using that on a daily basis. It is something that you have to transition to appropriately, and you have to make sure that you are the correct person to transition to some of these things. And along those same lines, like one of the tough parts about what we're talking to is there is a train of thought that sometimes doing the opposite of what I just said when you're having plantar fascia pain can be a temporary,
yes, that's the
temporary keyword, a way to help reduce the strain on it to allow the tissues to heal a little bit better. Whereas if you're having some of these symptoms, if you're at your wit's end, you've been dealing with plantar fascia pain for a long time, you might not want to just run out and buy the first minimalistic pair of shoes that you can get and just start wearing them 24 hours a day. That is not going to work well for you. You're going to need to allow the body to adapt to that. Mm-hmm. And it might be a 6-week, 6-month process to get to that, depending on there. You mentioned orthotics. Orthotics may be, again, a temporary way to shift some of the load away from the tissue that is not doing a great job at absorbing the forces that it should. It is not intended to be a long-term solution that I can't function without my insoles. We get people like that, and yes, it's never a always situation. There are people that do need it, but I'd ask yourself to be honest with yourself. Do you actually have a rigid foot that's fused and can never move again and you need an orthotic? There's very few people that I think fit that bill. That goes back to my earlier point. Like there's not many feet that I've met that I can't increase mobility. Yeah. But we see that, there's kind of two ends of the spectrum. Short term, we can shift loads and use our tools. There's taping techniques. Some of them have proven effective. Some of them have not proven effective there. There are different things that we can do to just shift that load and let the tissue get healthy. And hey, you're a couple weeks out from a marathon. You're in the middle of a training program. Let's do it. Let's go for it, right? But the long-term solution is then get you out of those, strengthen the foot, get you down, reducing some of the heel to toe drop that you're in, getting in a lower shoe, like a mid-range here. Like I tend to run in a topo that is a 3 to a 5 drop, which is a nice sweet spot for me. And some of my plantar fasciopathy came on because we sell some shoes in my clinic, and we didn't have my normal shoes, and I went to a 0 drop, and I just kind of went full force into it because it was like, I don't feel like ordering them right now. And that part of the reason that I developed it is because I am my own worst patient with that.
Amazing.
Yes. But we can see that there is a lot that you can do from it, from a shoe standpoint, thinking about that. And one other thing, and then I'd love to hear your thoughts on this too, Nathan.
Sure.
But I find with picking shoes that one of the most important things with this plantar fascia patient is making sure that they're tying their shoes correctly and that the shoe has the appropriate fit. We want it to be tight around the midfoot, like around the forefoot midfoot, and we want to have it loose at the toes to let the toes do what they need to do here. You and I even had a conversation before. We can also talk about plates and rockers, and there's lots of other things here. But I think the number one thing is just make sure that your foot's not like pistoning back and forth in the shoe, that your foot is secure in there, but it has room to do what it's supposed to do.
Yeah.
So let's hear your thoughts, Nathan, on this too. I'll flip it back on you.
No, I just want to start by saying I agree with everything that you said. Like there isn't anything that I'm on a different side of the fence on this. The part that gets me is that I think that in the running shoe world and just footwear world in general, when it comes to marketing, the most highly marketed thing is arch support to help with plantar fasciitis. That is the most kind of thing that you're going to see out there. And that's going to be in your inserts. That's going to be about the footwear itself, if it has some arch support. And I think a lot of that came because there's some literature that shows that short-term orthotic use, just like prefab, nothing fancy, some kind of cushioning in the heel can give short-term pain relief for people with plantar fascia pain. And that's a great thing. Like you said, it's this short-term temporary thing that can help decrease your symptoms for a little bit. And then companies take that and they say, look, we've created the shoe for plantar fascia pain now. This is going to be the thing that's going to help you forever. When really, the literature shows it's like a 2 to 3 week benefit. That's what it's for. It's this short-term thing. Same with taping. It's a short-term fix to help decrease irritability and then actually address the actual issues. So I don't even know where I was going to go from there, but I think it's the most highly marketed thing that is doing the exact opposite of what you need long-term, because the footwear is designed in a way to take the stress off of your plantar fascia, puts you a little bit maybe more to the outside of your foot, stops your foot from moving. That's the idea of some of these footwear too. It's like, hey, let's butt up against the arch so that it can't go through its mobility. And then it becomes a perpetuating cycle for people who are trying to improve from this condition. So the claims that this is helpful actually can be long-term detrimental to what you're doing, because in a good way, I have a pair of Vivo next to me and I've got my Zeros upstairs that I wear to work. As you kind of said, and knowing that there's complexity and it's not an always or nothing like you said, but if you can transition to a point where you can teach your foot to move, you can teach your different tissues to handle stress and strain, share it among muscles and tendons and your plantar fascia and all these different things, get the right mobility, that's going to be the way forward. And so I have so much beef with marketing that goes towards helping plantar fascia pain from footwear, and especially just this whole concept of arch support. It's going to feel good temporarily, but it's not the long-term fix. I'll pause. I have more to say, but I'll pause there and see if you have anything.
I wonder it. I'm trying to look this up real quickly now, but How much do you think people spend on plantar fascia gadgets and tools and things every year?
Oh my gosh. Like even just in the United States?
Yes.
Let's see if you can find this.
I'm asking ChatGPT here.
Let's see what Chat has to
say. Let's see if there's any statistics with this. It says searching the web, but while it's searching and while we're looking for that answer here, we don't have our own fact checkers. Oh, here it is. Approximately $284 million a year.
Yeah.
Now, this includes some like physician visits and medications and things like that, and orthotics and some of those other things. But I think there's a strong amount of people that are actually, buying the gadgets, the socks, the all the straps, everything that they're buying with that. But what I wonder with what you said is maybe part of the progression of the shoe industry, right? They said arch support, great. Well, that pushes everyone to the outside and doesn't let everyone naturally absorb the forces. Yeah. So next, they had to increase the cushion. Yeah. Because everyone's on this rigid foot. So now they need to make it feel comfortable because it's jarring. And, same kind of thing. Hey, like you put a very soft shoe under somebody with plantar fascia, they're going to feel great for the first couple steps in the store. Yeah. And then all of a sudden they're realizing how much they have to control that motion by the high stack height. They're in that position. They're going to have to really control their hip. They're going to have to control a lot of these different things. And, it's unfortunately we've gone it's that saying, like, if you're digging a hole in the wrong place, digging deeper doesn't help. Right. I think we're digging deeper in this hole of like arch support. And I see patients do this all the time where they come in and I need a shoe with really high arch support. I have to have a shoe with high arch support. I'm like, okay, let's talk about that. Let's see. It might not be true. And the shoe that feels best in the store might not always be the best one for you. I think the shoe fitting process, this is another hot take here. Yeah. The shoe fitting process is really missing out on how shoes affect your biomechanics. Yeah. We added a score to our Gait analysis system because we were seeing that we needed a quick way to show people, hey, how does this gait cue change your form? How does a shoe change your form? And people, when they're buying their shoes, are buying them. And then because running injuries have this 4 to 6 week delay, they're getting it like, well, I've had these shoes for 4 weeks. This can't be the shoes. Guess what? It might be the shoes a bit here. Like
injuries take time to build up.
They do. Totally. They really do. So I think we went on a bunch of tangents and soapboxes of mine here. But
I think to wrap up some shoe thoughts for me, at least, is when it comes to plantar fascia pain, your long-term solution won't be shoes. We're also not saying that, everyone should ditch their arch support that you do have in your shoes and just transition to something that has no support or just like going to barefoot. That's also not what we're saying. We're also not saying that's also automatically going to make you feel better right away. Right. I think we're trying to say that the underlying issues are more important to address than finding footwear to match you. And the last thing I will say is a nice short-term thing sometimes are utilizing, and I'm even stepping back a little bit, but sometimes having a rockered shoe with a little bit of a more rigid platform, whether that's plated or not plated rigidity, can be helpful in this short-term process too. If you're in a place where shoes can be a tool for you in a short-term space, like having something that's going to decrease overall load on the plantar surface of the foot could help you get through some of this irritability or get through the race that you're going into or whatever, as you then go and address kind of these deeper levels of things. So as we kind of wrap things up here, Doug, I think the last conversation I want to hear from you is just kind of what are your biggest tips for people who've been dealing with plantar fascia pain, where if you're by yourself, you don't have a physical therapist you're working with, it's been something that's bugging you for 5 to 10 years or even just like 6 months, where would you start if you were just by yourself? What would be the things you would try to attack?
Yeah, wow, that's a great question here because I mean, my first response would be like talk to a physical therapist or even like
Me too.
get on get on a virtual visit with somebody and that could actually even assess some of these things. But it goes back to what you were just saying. It's got to be personalized and you got to get to the root cause of it. Throwing a bunch of things to the wall and seeing what sticks is going to lead to more frustration. Whereas, the rocker bottom shit, like that could be great for somebody, but you're going to spend $160 on that pair of shoes, and you might have really good hallux dorsiflexion, and maybe that's not going to help you as much as somebody else that has very limited ankle hallux dorsiflexion because the rigid and rocker is going to prevent some of that toe extension, but maybe that's fine for you and that's not symptom provocation for you, and you've got motion and you've got control over it. So having somebody quarterback the care and look at it is really going to be helpful. And I think most people are going to have access, and you're going to have to figure out what's this worth to you, right? I think if you start asking yourself, what am I really willing to do to get rid of this foot pain? What actually am I willing? Like, am I willing to throw resources at this or not? Because you might try things like, we said shockwave. Like, we're seeing that it can be really helpful in short term, and some of the longer term benefits there's some debate about that in the literature, but there's good reports of helping out in the short term at least. So if you do have a race coming up, you might want to explore some of those things, but realize that there's cost benefit. You might not want to run for 2 days after you get a shockwave treatment here. So you have to look at some of those things, which is why we've tended to go towards the win-back Tecker therapy, because you can run right after it and there's not as much, and we're still seeing changes with it. So now to answer the question more of like, hey, yeah, you're on an island and you've got nobody, you got no communication. I would just really do some simple assessments just to see, and here's some quick things that you can check to see how you're doing. So first, I would look at like a dorsiflexion motion here, because that could be a really huge thing that you need to get. So the easiest way to self-check this is just to kneel in a position and take your hand. So put your toes a hand width away from the wall and see if you can kneel forward and get your knee cap to touch the wall without twisting your body and without the heel coming up. If you're limited in some ankle range of motion, I would start working on getting that motion back, doing calf raises, working on the soft tissue structures. If you can get somebody to mobilize the joint, that would be great too. Then the next thing I would do is assess your arch and your hallux at the same time, your big toe. I would just ask you to sit with your knees and hips bent 90 degrees, and I would say lift your big toe up. Can you lift your big toe up, keeping the little toes on the ground? That's going to tell if you're able to stabilize the arch in order to raise that big toe, and it's also going to give us an idea of how much motion you have. So that would be something I really look at. And then I'd probably look at calf strength as well, and look at somebody doing a single leg calf raise and watch that person that like goes excessively out to the side, making sure that you can do a calf raise nice and tall. You can do 10 of them on single leg and you're feeling pretty good. If you can do those three things, well, I probably had one more. I probably had balance too. I would do a balance test, and I would watch while I'm doing balance. Am I able to keep the foot tripod during balance, right? And if you're not familiar with that, is there video with this?
Yes.
I keep doing hand gestures. So
there is.
So basically, like the foot tripod is underneath of your big toe, underneath of your little toe, and kind of in the center, like not exactly those points, but make a triangle here, and see if you're able to put weight fairly evenly distributed between those 3 points. A lot of people that have poor balance, when I look at them, I see what happens when they come onto that medial spot. And most of the time, you're going to see people are just going to fall right over here. And if you have trouble with things like that, there's lots of great tools out there. Jay DeSherry's mobile board, great way to work on some of the stability with that and learn how to bear weight through that first ray. So I would say those 4 things for self-assessment would be where I would start to see if you can just find out, maybe address some of those mobility restrictions first and foremost. And then when you're walking, try to walk as symmetrically and even as you can. If you're on an island, I guess there's 5 things that you can do that will help you at least start to progress towards getting over some of these symptoms.
Fantastic. Well, Doug, thank you for all of your time. Before we wrap up, can you just tell people where they can find you and what sort of resources they could access through you and through Run DNA?
Yeah, I think we talked a lot about gait analysis tonight. So I would say if you're a runner looking to get a gait analysis, you should head over to rundna.com and go to resources and find a provider. This is one of the things that we have trained thousands of people in our education, tens of thousands in our education, and then we have hundreds of sites that are doing our 3D technology. So finding somebody that can help you out and be that guide is a big part of it. And then while you're there, you can sign up for our newsletter, or you can check out our Instagram, which is Run DNA System, I want to say. For Instagram, you can check that out as well. But we're very engaged and open, and both for the medical community, the fitness community, but as well as just runners and walkers. I think a lot of this can make a big impact on that. And we try to put up resources all the time to help people out with this stuff.
Fantastic. Well, thank you again for all of your time. We record on Sunday nights, so thank you for giving us your Sunday night and for all the wisdom you shared with us today.
I really appreciate you having me on. This was another great, fun conversation, and enjoy the time. And thank you for your opportunity here to be here.
Absolutely.